This talk, an annual talk for quite a number of years, I try and focus on a mixture of the commonly needed information that people encountering bipolar disorder and their families experience, maybe at the outset of an illness and in the early stages of its management. Some of it will seem repetitious for people who are highly experienced in these areas, but also to talk about the skills needed for staying well. So it's really about trying to give you an understanding of the illness, its basis, its signs and symptoms, what causes it, what impact it has on people's lives, and what people can do to stay well. I will also deal very briefly with, as usual, one interesting topic that's emerged from the research literature over the past year or so, and it's in connection with sleep apnea and its relationship to bipolar disorder. The term bipolar disorder obviously implies that there are two poles to the condition, a high and a low. It replaces the term manic depressive illness. Hopefully it has lost none of its meaning in that sense. But in a curious way, the term manic depressive illness had a lot of meaning hidden behind those two words, even though we maybe didn't quite understand them. Manic actually means speed it up. People often mix the word up with maniac. Depressed or depressive means slowed up. And in essence, that's basically what bipolar disorder is about. It's essentially a condition of alternating overactivity and underactivity within a variety of different systems within the body, but largely overactivity of emotion and thinking. And it's spelling that out and seeing how those interrelate to form the classical symptoms of the condition. Whereas it is called bipolar disorder, for some people, though, they will mainly have one pole of it. So there are two poles, as I say, the high and the low. The high side, or the manic side, and the depressed side can be represented in this way. But for many people, the lows are the main aspect, and the high they may get might be very slight indeed. For other people, then, it's where the highs are the predominant feature and the lows are fairly slight. For some people, just to cause a little bit of confusion for some people, is that the highs for quite a number of years of the condition, sorry, that should go there. So in other words, the person may just have highs and no lows. So why then still call it bipolar disorder? Well, it is just called that, and we just have to accept that anomaly. In other words, there are some people who will have highs only, certainly for a number of years of the condition. That is, when it is untreated. So more recently, another term that has emerged from research is what's called bipolar spectrum. And it comes back to this very important point, that even small amounts of elation in themselves are extremely important to recognize and to have effectively treated. Now, a person might say, well, it's only a small amount of a high. My sleep was only upset for a night or two. Okay, I was over-talkative and I said things I shouldn't have said during those 2 or 3 days. But the point is that if that high is left unchecked and untreated, what it means is that ultimately the depression that happens subsequently will continue to occur if the person is having these small highs that go unchecked. So, whereas the individual person, if they had a small depression like that, they would be quite well aware of it. They'd be able to remember it, tell you exactly when it started, when it ended. But people, by the very nature of the condition, are relatively unaware of highs. It's often the person around the individual that can spot it. So what I want to do now is just to, having explained a little bit about the concept of bipolarity, where it emerges out of manic depressive illness, and the concept then of bipolar spectrum. In other words, you have different spectrums. The more severe unipolar mania, recurring depression, slight highs, waves up and down. You've a whole spectrum of minor degrees of bipolarity that can maybe almost appear as if it's affecting a person's personality, and it gets diagnosed mistakenly as a personality disorder, whereas in fact behind that there's a very definite mood disorder. So let's go and look at the signs and symptoms. And again, I'm just dealing with this for people who are coming to it afresh. So within depression, it's useful to look at it from this point of view, that within depression, if you imagine that within your mind you have a thinking wheel that rotates at a certain rate, we're quite used to that rate, our rate of speech, our rate of thought, our rate of facial expression, whatever it may be. When a person gets depressed, that slows down. And because it slows down, you can begin to see that the whole person's appearance changes. They become less expressive. Their eyes are more vacant. The person is inclined to stare into space. The person has less to say. They find it hard to string sentences together. Words just don't seem to come. Quips seem impossible. And bit by bit, the person's whole demeanour changes in the sense of the length of the strides they take. They're just bodily gestures. Until eventually the person is seen as somebody who is in a depressed state, even from a distance. But if you take it that this is related to the driven machine of thinking up here that's going at a certain rate. So you can conveniently look at bipolar disorder as a disorder of emotion, or of energy, or of thinking. I think it's convenient to look at it as a disorder of rate of thinking. In other words, that's that core to it. Because when it comes to sort of teasing apart different diagnoses within this, one has to have some sort of framework on which to look at it. So basically what happens in depression is that the thinking wheel slows down. Because of that, the person has less to say, they're less expressive. Now, the next thing that happens from that is that the person has difficulty putting their thoughts out into space of their mind. In other words, when you ask somebody how it is they see the future, what's ahead for them, most people, if they're not depressed, will look to the left or right, and within an instant they'd say, well, I'm looking forward to that game tonight, if only you'd get on with this lecture. Okay? Or somebody might say, I'm thinking of a holiday at the beginning of August. I really am looking forward to heading down the country and having a nice, relaxed time. So in other words, we have that capacity to put a picture up on the visual display unit in our mind. But that almost seems to need a certain momentum from this wheel where we can spin thoughts off. And that thus also creates our sense of future. So when people are very depressed, they just simply can't do that. And what happens is that if you ask them, how do you see the future? What they will say, it's bleak, it's blank, or there's nothing there. So it's amazing how often people actually use those words, not realizing the significance of what they're saying. But if I note, as I do when people are describing their sense of the future, these three terms keep cropping up. And what it says is the nothingness of the future. So a person can feel disconnected, and it's very frightening for people in that state because we take that sense of the future so much for granted. Now, the next thing is that because there's nothing there on this slate or on this visual display unit, a person doesn't have the energy to pursue the future. We think energy is something that comes from glucose and other things that we take. Yeah, sure, it's important, and having blood pressure and having a reasonable hemoglobin, they're all important. But in terms of the energy that we take for granted in everyday life, it's really a figment of our imagination. We throw something up here on the visual display unit and we chase after it. That's what our energy is. When there's nothing on the visual display unit, everything seems difficult, empty. It's very hard for a person to have any initiative or any drive or motivation. When we're burdened by major problems in our life, there's a mountain there ahead of us, and that is depressing. It impedes us taking action. So, in a sense, we create our own energy if we have the mood to do it. So again, you can see how all of these things are connected with the rate of thinking. I hope some of this is beginning to make some sense for you. The next thing is that we have trouble, when depressed, taking information in, because information comes in like this, like a string of dots, and they have to fit on to. It's as if one bit goes there, the next bit should go there, the next bit over here, and so on. And we string that information together. And it's as if then that eventually goes into a thinking wheel on which all that information is kept. Now, what happens when a person is depressed, because the wheel is rotating so slowly, the information is coming in and it just all gets lodged in the first lot. And the brain just can't cope with it and process the information. Likewise, because the memory wheel is slowed down during depression, a person has difficulty accessing information. So at this point here, the person's ability to absorb information, i.e. to concentrate and take information in, is impaired. And when a person is depressed, the thinking wheel is slowed up. It's not that the person has lost their memories, they just can't readily access them. But it's really when people say their memory is affected during depression, it's actually more their concentration. In other words, that if you slow the thing down and give them the same information and really get their attention, they can take the stuff in. But many people of an older age group, as they begin to get depressed, they will point to their memory and maybe incorrectly believe that it's the onset of Alzheimer's. So they're the key symptoms of depression, a slowing down of the whole process. Now, in elation, you've got the complete opposite. We use the word elation, mania, which is really speeded up state, and the other term would be hypomania, as a lesser degree of mania. So with the thinking wheel now, what's happening is that it's going much quicker than normal. And that's great fun initially. The person has a lot of things to say, a lot of ideas, everything seems to be attracting the person's attention. So, in other words, all this information the person can really absorb, lots of phone numbers, lots of names, and seems to have it all in that sense. But as the thinking wheel goes more quickly, it's just absolutely taking up nothing. It's going so fast, absorbing nothing. So you can see people who will go through, for example, maybe a prolonged hospitalization during a manic episode. And their recollection of the length of time they were in hospital or the treatments they've had or who visited them, almost nothing registers. A person might believe, for example, and I exaggerate not, they may say, I was in hospital for 3 days. It could have been 3 months. And it's not that they were so medicated that they were unable to recall it. It's just simply that the ability to absorb information from their environment is limited because the person is so into their own thoughts, they've got so many of them. In other words, they dominate the person's thinking. So that when you're looking at a person who is depressed, they're vacant, their eyes are vacant, they're staring into space. Whereas when a person is high or elated, they're thinking so quickly, their eyes are darting from one picture to another. And what the pictures are that the person is throwing thoughts up here, here, and so on. And they're jumping from one picture to another in their mind. So you can see that aliveness, or the person's eyes dancing during a high state. Again, because there's so many things up here on these pictures, the person has tremendous energy. They can manage then to keep pursuing things incessantly. But frequently they will jump from one thing to another and maybe not finish one task before they move on to another one. The result of all of this is that the person is over-talkative, restless, impatient, energetic, enthusiastic, able to concentrate on an enormous number of things. But frequently, their judgment is impaired. And let's look at just the anatomy of judgment in that sense for a moment. So when we have a decision to make, what happens is we jump up from this point to this point. The thought might be, I want to go on a particular holiday. So we'd look at the positive side of that. Yes, it would be a very enjoyable thing to do. I had fond memories of being there before. The rest of the family would enjoy it, and so forth. The negative side would be, I can't afford it. Some of the aspects of that holiday weren't all that pleasant for everybody, and we weigh things up carefully in that way. When people are depressed, they will only tend to see the negative side. I can't afford it. It's too far to drive. The temperature's too hot. It probably will be raining, whatever. In other words, sorry, I seem to have touched somebody's cord there. So in that way, we arrive at decisions. When somebody's high, they can only see the positive side. Everyone will enjoy it. I'm going to bring everybody, the family, the extended family, and John and Tommy on either side of it can come too. In other words, the person ignores the cost, whether it's something that the neighbours and the extended family really want, whether they can take off time, work, etc. That the person will jump from one decision to another in a high state and only see the positive side. And that's where the damage is done. In other words, that the balance between constantly weighing up carefully, which we do in an instant when our mood is okay. We can arrive at a balanced decision that's right for us. But when a person is high or low, there are difficulties with the decision-making process. But in a low state, because of the inability to enact the negative decision, the person doesn't have the energy or the drive to do something about it, generally it doesn't cause as much trouble. But for example, if you're a shopkeeper and decide, I can't afford to buy stock, when you can afford to buy stock, well, that's obviously going to fairly profoundly affect your business. But it's more people who are in the high state that are more likely to get into major difficulties with poor decisions during that time. So we can trace the elements of bipolar disorder back to an underactivity or an overactivity of the thinking process. And it's often called psychomotor slowing. In other words, the mind slowing and the body slowing as part of depression, and psychomotor hyperactivity as being the opposite. And they're just terms to describe what because that's what one would look for in terms of trying to make the diagnosis of this condition. Okay? So let's now look at the individual signs and symptoms within this, and we use the mnemonic festival to try and help us remember what this is. So during depression, a person will feel low, sad, depressed, sometimes mainly anxious. Remember that people who are anxious by nature, when they get depressed, they simply get more anxious. Now, behind that symptom of anxiety, there are the typical features of depression in terms of maybe disturbed appetite, disturbed sleep, poor energy, poor concentration. But the person does not like being told your diagnosis is that you're currently depressed, when actually all they're feeling is anxiousness. But bit by bit, the person will begin to realize that. So in other words, we need to bear in mind the importance of anxiousness in that sense. E is energy. The most common symptom, from what I can see, of people with depression and bipolar disorder is a disturbance of energy. People feel tired, and that tiredness is not relieved by a good night's sleep. Sometimes people will describe it as a mental tiredness, other people will describe it in a very physical way. In sleep, disturbance as part of depression, the person will have broken sleep, generally from 3 p.m. or 3 a.m. onwards, broken sleep, early morning wakening, and maybe oversleeping during the day. T is for thinking. In depression, as we said, the thinking is slowed down, with the result that the person has difficulty concentrating. They may feel wooden-headed, and can't focus mentally, would be another way of putting it. I is for interest, the interest a person has in the world around them. When we have the emotion, we can express it and interact with the world around us. Colours, people's faces, what people say, things that attract us. What happens in depression is that they all shrink, and they will often be most noticed by a person to affect the thing that they consider particularly important to them. It may be food, it may be the daily newspaper, it may be soaps, it may be interest or affection for their family. Any of those things may be affected. Even football. Guys do come in and say, I know I'm depressed, I stop following the local team. Hard for women to believe, but it does happen. So it's food, sex, religion, whatever it is that's particularly important to a person. Value, V for value, the value a person puts on themselves, may range from I'm not a very good person, right over to useless, and to the far extreme would be damned or wicked. Next, A is for aches. As part of depression, there's frequently a tightness in the muscles, a tension in the body. And for many people, that's felt as a headache, backache, chest pain, or if the person had an old injury from work or from sport or something like that, that injury, for example, within a muscle, as those muscles become tight around the injury, that original pain will be reactivated, like a pain in the leg or whatever. So there are many people for whom, when they're first getting depressed again, that is the first symptom that they are aware of. And L is for live, basically not wanting to live and feeling suicidal. And very often the suicidal feeling is related to the sense that there's nothing there in the world, that the person is disconnected from the world. So even if you cannot identify all of the symptoms, the point is that it's a disturbance of feeling, energy, sleep and thinking. And really if, for example, if somebody says they're very depressed, but their energy is okay, well, it's probably not depression. They may be distressed by what's happening in the world around them, but if they haven't those core symptoms of depression, it's unlikely to be depressed, that the person is depressed. On the other hand, if 4 or 5 of those main symptoms are present, and they've been present for, we say, 2-ish weeks or thereabouts, the chances of it being depression is very high indeed. Now, it can be other things such as anemia, an underactive thyroid and so forth, but the frequency with which depression would explain that level of tiredness, fatigue and sleep disturbance would be much higher. Now, in elation, you get the complete opposite. Rather than feeling sad, depressed and anxious, the person feels extremely energetic and enthusiastic. So, elated, optimistic, never felt better. They would be typical statements a person would make, and they might say, I don't know why I'm here talking to you. I have never felt better. I can't understand why my family insists that I see somebody. Energy, super. And need little sleep. In other words, the person might find that they can't switch off and go to sleep. The person may complain of their thinking. It may be very energetic thinking, as it were. Very lively thinking. On the other hand, the person may feel that their mind won't switch off. Now, with the result, that actually it forms the basis for the person's trouble getting to sleep at night. In other words, because the person can't switch off their mind, they're not able to go into sleep at night. And thus, that's a very typical manifestation of elation. Often people think that when people are depressed that they have trouble getting to sleep at night. To my mind, that's unusual. If a person has marked trouble getting to sleep at night, it more than likely is a reflection that the person's mind is overactive. Now you can see maybe all the time I'm coming back to the same concept, that if it is bipolar, the person's thinking is going to be slowed down, and one should be able to see that in the process of talking to the person, watching their expressions. If their mind is overactive, you would see it in things like their eye movements, their gestures, their interruptiveness in conversation, the tendency to dominate the exchanges and so forth. Interest. Will be for 1,001 things. In other words, the person will jump from one interest to another. Or as somebody says, everything that glitters seems like gold to the individual. They're just attracted to absolutely everything. The value they'll put on themselves is that they're great, or the greatest, or greater than the great. Okay? Aches and pains. Curiously, aches and pains disappear almost when people go high. L is for live. When a person is high, as far as they're concerned, they're going to live forever. Now, I've been talking about elation in this sense, but there is another aspect to this that we need to look at, and it's an important aspect. And because not all highs or manic phases are pleasant elations by any means. So let's just look at when a person is going into depression to start with. When people go into depression, frequently at this phase, and at this phase as they come out of it, they will often experience anxiety. And it's only when they go down further into depression that the brain begins to slow down and switch off. Now, curiously, that phase and that phase are, from a feeling point of view, more harder for the individual person in the depressed state to cope with, because it's almost as if the brain slightly switches off at this point. Is that clear enough? In elation, what happens is that, or in a high state, always during a high, there will be little times where the person gets sort of a little bit agitated, even though it's a pleasant high. And during that phase, the person might, if you stop them and ask them how are they will say they feel depressed. And they might be weepy and maybe frustrated. Now, in that particular state, what's happening is that you realize that it's not a depressed state as such. They're just momentary disturbances of feeling, because you saw them a few minutes beforehand and they were talkative, joyous, elated, in great form, full of thoughts and plans. And you could meet them again 10 minutes after this episode and their mood would have shifted again. So that variation in mood is quite normal during an elation. But it's easy enough for families and others to see that the person is still pleasantly high. But there are some people who, right throughout their elation, have this depressed, weepy, frustrated state. And if you ask them how they feel, they're convinced they're depressed. They will convince their family they're depressed. They will convince their doctor they are depressed. And for all intents and purposes, yes, they are depressed. But there's one important difference. And the important difference is, in this state of depression, a true depression, the person's thinking brain and motor function in their body is slowed down. This person, even though they're saying they're depressed, they feel depressed, but if you stop and look at them, they're still quite talkative. Their eyes are still dancing. They're agitated. They're still highly expressive. They will talk about the intense awfulness of their feeling. They're in extreme distress. But the volume of their voice is up. They're still talking rapidly. They will tell you they have trouble getting to sleep at night. They will tell you that they can't switch off their mind at night. So it is quite different in a sense. So it is not depression in the true sense. It's what we called an unpleasant high, also known as dysphoric, meaning an unpleasant mood, a dysphoric hypomania, and you will also hear it referred to as mixed moods. In other words, people emphasize in that way the mixture of depression and elation. In other words, yes, the sort of overactivity of the mind is there, the racing thoughts, the energy, the sleep disturbance of a high, but mixed in with that is depression. I tend to favour either this term or this term for a very good reason. One is that, yes, from a purely symptom point of view, it is mixed moods that are present, that's for sure. But the reality of it is when you come to treat it, you have to treat it as if it were an elation, because If you treat that with antidepressants, you tend to make it worse. Whereas something that's used to treat elation, such as olanzapine or haloperidol, Serenase, Risperdal, things like that, they immediately have a calming effect within hours of this condition. Secondly, in this unpleasant mixed mood state, it's not unusual for people to go untreated for a long time or mistakenly treated as having depression. But it carries quite a high suicide rate with it, because the person still has the energy now and the frustration and the awfulness of their feelings churning around in their head, and often the person will be maybe very angry with people around them, get into fights, but also can turn on themselves and want to end their lives fairly quickly. So these unpleasant high states are actually quite hard to spot, but it's very, very important in the management of bipolar disorder that they're dealt with fairly quickly. Moving on now to talk about some of the complications that occur. You get disruption in relationships. Secondly, people use alcohol. Street drugs as a way of quelling the unquiet mind that they're experiencing. And there's no doubt that as many as 50% of people with certain types of mood disorders do end up becoming dependent on alcohol, and that has to be treated in its own right as a separate problem. Simply treating the person's unstable mood is not going to get rid of the addictive process that has started, and nor is simply staying off drink going to sort out the moods. So both of them have become problems in their own right and need individual management. People accumulate major debts. People with highs and lows or bipolar disorder often have tremendous energy, tremendous ideas, are very creative, very energetic, are maybe very good at their work, very determined, very driven, and they build up a lot of resources in their lives in many ways. But then when the lows happen or the highs get out of hand, all of those things are lost. So it's very seesaw, or in a sense has become part of the common language. A person ends up leading a bipolar existence. Now, the mortality with untreated bipolar disorder is something like 15%. It's extremely high. And the occurrence of bipolar disorder in the general population for what we call bipolar 1, which is a big high followed by a low, the lifetime occurrence of that is about 1%. So the 1% of the general population in the course of the lifetime will have that type of pattern. But then when you look at bipolar spectrum, in other words, lesser degrees of highs and lows, what you'll find is that the figure goes up to maybe up as far as 5 to 6%. Now, some researchers would say it's much higher than that, and that some people would maintain that any very severe depression, if you look at it carefully enough, that that person has had little bits of highs that have gone unnoticed. And there's a fair bit of evidence to support that. For example, we know that in the course of, say, if you take a group of people who develop recurring depression in their teens or early 20s and follow them into adulthood, you will find that at least 1/3 go on to develop bipolar disorder. Secondly, if you take people attending the average clinic where everyone in the clinic is supposed to have depression, you will find that probably a third of those are at that clinic believing they've got depression, but they don't. Now, the way we discovered this is that within Aware, when people came along to support groups, believing they were depressed, it's not unusual for people to go away even after the first meeting and realise, no, I get highs and lows, or I get unpleasant highs, but they didn't actually recognise it as such. And the reason it's hard for doctors, particularly doctors that mightn't know the patient that well, to spot the highs is that people don't come in and say, I'm high, I'm in great form, I'm here for treatment, because it's not painful enough. Painful for those living at home and dealing with and supporting the individual, but not always for the individual themselves. What causes bipolar disorder? Well, just giving you a very brief overview of it, what we know from studies that have been conducted both at sort of within families, between families, within twins, and between identical and non-identical twins, and twins that are at birth maybe separated in the course of wars or other things and brought up in different environments, and one twin goes on to develop bipolar disorder and the other doesn't. What we have come to understand is that from these family studies, so in other words, within any family, if one person has bipolar disorder, we say bipolar 1 disorder, there's about a 15% chance that one of the offspring will have depression or bipolar disorder. Within twins that are identical twins, what you will find is that if one has bipolar disorder, that as many as 70% of the fellow twins will have the same condition. Now you might say, well, they're brought up together, they look alike, talk alike, go to the same school, wear the same clothes, why wouldn't they have the same illness? Well, if you take twins that are separated at birth, identical twins, what you will find is pretty much the same sort of figure emerges. And even in those instances, for that, we say the other 30%, people would say, well, what about the other 30% that didn't develop the condition? What you will find is the offspring of those who didn't develop the condition, their offspring developed bipolar disorder at the rate you would have expected within a family setting. So no matter what way research has looked at this is what keeps emerging from it. However, we do not know what genes are involved. There's some thoughts about different genes, but it's turned out to be extremely complex, the whole genetic aspect of this. So what we need to try and understand is that for a person to go and develop bipolar disorder, what tends to happen is that they might have, on average, a contribution something like 70% genetic and 30% is related to their environment, their childhood experiences, and that determines the 100% figure, and thus bipolar emerges. But that is an average figure, and it's not very, it's important not to get too honed in on that, because there will be some people for whom the figure is the other way around, 30% genetic and 70% environmental. In other words, where the person went through a very traumatic and upsetting experience in their childhood, and there's little or no history of bipolar or mood disorder in their family, but maybe a number of uncles who drank in bouts in a way that some people would feel is almost a form of bipolar drinking. There'll be other people where it's 90% genetic and 10% environmental. And in that instance, what's basically happening is that the person might have 1 or 2 or 3 siblings and or parents who have the same illness. And in that instance, it takes little or no environmental effect. It could be just simply the change of seasons is enough to trigger the onset of that person's first depression or elation, or their first trip abroad, or it can be something really quite simple. So what we know is that from an environmental point of view, there are certain things that can trigger it, but it tends to be in instances where there's already a genetic predisposition. Our ability to tease out the genes is now halted at a point because our understanding of genetics, not just genetics of the mind, actually doesn't extend beyond that. And this has emerged from the study of genetic conditions of mental health over the past 10 to 20 years. In other words, it's reached its scientific limitation at the moment because of the complex structure and interaction of genes. It's not just simply about bipolar disorder. But what do we know about the environmental things? Well, a lot of people point to early childhood experiences as being determinants of developing a bipolar disorder. That's actually quite a complex one and not one that's easily dealt with, because what you will find is that you could have maybe two brothers and a sister in the same environment. They experienced exactly the same exposure within the family, being born almost within a year of one another, maybe in the middle of a larger family, and lo and behold, maybe just one person develops the condition. So it's not that simple. What we do know is that people who have a tendency to bipolar disorder or depression, probably more of the life events and upsetting factors in their lives are inclined to stick to them. In other words, some people just, even as children, have an ability to shrug things off. Oh, well, he was losing the head for a while, for a few days, the old man, and that was the way it was. For somebody else, that just sticks to them, and it just lodges in them, and they don't seem to be able to process it. So the actual processing of events may have been affected in a quiet way by the illness at an early stage. Certainly from an observational point of view, I would get the impression that that's what happens. What's important is anything that disrupts sleep once a person gets into their teens is important. So whether it's heading off to the sun, getting a bad dose of sunburn, or drinking too much with your leaving cert buddies can be the reason why a person will have their first episode of high. So disrupting sleep, if you take somebody who has a tendency or a history of bipolar disorder and want to make them high, just stop them sleeping for a night or two and off they go. So it's in one way as simple as that. So things like tea, coffee, stimulants of any sort are highly dangerous. Street drugs, alcohol have a much more profoundly disturbing effect on people's minds where there's a history or a tendency within that family to bipolar disorder. So it's very important that parents are careful in that sense around children, and the children are aware of that sort of risk. So it's almost as if the person who has a tendency, latent or expressed, of bipolar condition, that alcohol, caffeine, steroids, other things like that have a much more powerful punching effect on their mood than for the average person. And as I said, the same goes for street drugs. Now, let's deal with, very briefly, the next three topics I want to deal with. One is the management of bipolar disorder. The second is dealing with sleep apnea. And the third is a list of the do's and don'ts that people should be aware of. So from a treatment point of view, the main treatment for bipolar disorder are mood-stabilizing agents. And the reason we talk about mood-stabilizing agents is that bipolar disorder, by its very nature, tends to be a recurring condition. But the whole emphasis really has to be on preventing the next episode. So if we look at what's called bipolar 1 disorder, this is bipolar 1. In other words, a big high and a big low. And by a big high, I mean a high that's bad enough to land a person in hospital. Now, for a condition such as that, lithium is still reckoned to be the treatment of first choice. So what it's basically doing is trying to prevent the next upswing, because if you can prevent the next upswing, the downswing isn't as bad or isn't as intense. Now, frequently then the person will need maybe some other compound to lift them out of and keep them out of the depression, and that may be a substance called lamictal, which is an anticonvulsant compound with very gentle antidepressant effect. For other people, you will find that carbamazepine. Epilim is often then used as an alternative to lithium for people who can't go on lithium in these instances and can be effective. However, research over the past 4 to 5 years has clearly shown in these instances that lithium is superior to epilim. And sometimes the adding of lithium and epilim together doesn't really convey any greater benefit than lithium on its own. Bipolar 2 is maybe where a person has had recurring depression sometimes for a certain phase in their life, and then as they come out of the depression, they begin to have highs. And then as time goes on, the highs get a bit bigger, and the interval between the depressions can get shorter. So what's used in those instances as the primary treatment would be something like epilim or tegretol. But there's an awful lot of individual tailoring because it varies an awful lot from person to person. Now, the next pattern that you'll hear about is what's called rapid cycling mood disorder. And that's where a person has 4 or more mood swings in the year. Now, in those instances, your total emphasis has to be initially on trying to get a mood stabilizer that will deal with the highs. You would tend to start with something like epilim, less so tegretol, and another class of drug would be what are called antipsychotic stabilizers. And they're things like Zyprexa, Seroquel, risperidone. So the whole trick is trying to deal with the highs. Now, next thing, just briefly, and this is very brief, is about sleep apnea. Sleep apnea is a condition where people go through a prolonged pause during their sleep. In other words, you're looking at the person asleep and there's no breath being taken for quite a lengthy period of time. And then their whole body shudders and they seem to inhale the whole room. In other words, and then there's a snore. Now, what happens is in those states is that there's something either at a central level in the person's respiratory system in the brain that drives breathing, or the person's physical build or their weight is causing what's called an obstructive apnea. In other words, that when a person lies down and they're sort of tucked in like that at night, all of the tissues around here and the soft palate at the back of the mouth and the tongue going backwards into the mouth, all of those things obstruct the breathing process. There's some implication that it's associated with bipolar disorder. There's a recent study, and until it's replicated, I wouldn't go so far as to say it, that as many as 50% of people allegedly have this tendency. Now, the do's and don'ts. Number 1, know your illness. It is yours. Acknowledge it. Understandably, people go to all sorts of lengths to deny it to themselves. Denying, well, it won't be that bad if I don't take lithium, therefore my illness isn't that bad. People will use all sorts of other words to describe, or terms to describe their symptoms and their condition, and won't necessarily be bipolar disorder. Again, it's understandable, but there's a sort of a lack of truth in that. See, it's not so much necessarily how the person dialogues with the world around them about it, but it also means that they're actually hiding the facts from themselves. Illness is a hard thing to cope with. Managing it is a hard thing to cope with. But the biggest thing for many, many people with bipolar disorder is recognizing it and accepting it for what it is, so that you can give it a decent battle and overcome it. So acknowledging it just means talking to people, letting people know about it in the family, bringing the family on board so that they have an understanding of what it is, because they can help and be supportive. To say it's nothing to do with them, it's none of their business, is not really going to be terribly helpful, because you are tied to them, whether you like it or not, by your emotions, and when emotions get disturbed, it's bound to affect the relationships in the family. So know the signs and symptoms. Get emotional support from family, people you're close to. Confide in somebody. And if you have the courage to do it, go to a support group, because they're fantastic at helping people realise that they're not alone, that it is something that can be treated, and that they can also help others. So in other words, no matter how bad you are, there's somebody always worse. And that helps all round. But time and time again in the aware support groups, no matter where they're held, no matter what age of people go to it, you find it's the same thing. People go because they realise when they do, they're not alone. 2, they see others with the same condition. 3, other people can help them. 4, they can help others. And every survey Aware is done, that's always the stuff that comes up. Very simple, very straightforward, but extremely, extremely effective. Now the next thing is spotting the illness. There are 3 ways you can spot the illness, or the highs in particular, because, see, most people recognise depression, although some don't, particularly men. They'll say it's the flu or whatever, the virus, or... So, the ordinary signs and symptoms that we've mentioned, in other words, sleep disturbance, energy disturbance, the festival symptoms that I've listed. The second one is what one would call personal signs. Now, what a personal sign is this, that when a person is high or low, they will do things that's characteristic of them at that time, that they don't actually spot themselves. And it's very important that, the family will frequently know what that sign or symptom is. So, I gave you one earlier on. John, who never smokes, only smokes when he's going high. Somebody else will wear an item of clothing. Somebody else will want to sow an acre of potatoes. Somebody else will want to travel to China. Nothing wrong with any of those things in their own right. That's not the point. The point is the person isn't thinking about that every day of their lives. It's just when their mood is up. Okay? And the family begin to recognise that, and they can use that information to try and help the person spot the high. Relatives can see highs just by the way a person holds their head, the loudness of their voice, their tone on the phone, whatever it may be. The person who's depressed will generally spot their depression first. So what you need eventually is to appoint a spotter. And what a spotter is, support group members came up with this term, is somebody who you trust to help you identify when your mood changes. In other words, if somebody's going a bit high, that they have somebody there who will gently tap them on the shoulder and say, maybe your mood is up a bit, do you think we might need to go and see the doctor? The purpose behind that is that if you can spot a high quickly, it can be dealt with within a matter of hours. If it's let run and the person is at full tilt by the time they go and get help for it, where they're not getting any sleep at night, they've been off work, they've been disruptive in what they're doing, the result is that major damage is done. So the purpose behind all of this process is really the do's and don'ts, is about good management and preventing complications. See, bipolar disorder eventually settles down, but there mightn't be much left in life, in relationships and incomes and so on, by the time it's settled. Number 6 is tablets. Know them. And that means the names, side effects, dosages, so on. Tablet box. Get a tablet box. It's impossible to remember whether you've taken a tablet that day. Number 7, alcohol. Know your limits. If you can't keep to your limits, i.e. A max of 2 drinks at any one time, maybe it's best to be thinking to be without it. To watch out for things like coffee and so forth. In other words, if a person finds when they take coffee beyond a certain amount, it has quite a buzz effect for them, or it's keeping them awake at night, well then they're on too much. In other words, keep cutting it down until that's no longer happening. And the final thing I'm going to mention is deal with hurt. In the course of a depression or elation, particularly an elation, people will do or say things that are extremely upsetting to others, particularly close family members. When the person goes to hospital or whatever and the whole thing settles down, the person who's unwell is embarrassed about it and doesn't want to hear about it. The next of kin says, oh, well, he was unwell or she was ill or whatever it may be, and they don't want to bring it up. But what happens then is all that hurt gets swept under the carpet. And when it does, that's okay, maybe once off. But that pattern of behaviour will be repeated each time the person relapses. And eventually, suddenly, that relationship ends. The important thing is that a person stops and deals with the hurts they've caused others. It means going to the individual concerned and saying, look, I called you during that high. I did such and such in the house. I did such and such in terms of money that was squandered and so on. And it's to acknowledge that. Now, the point of acknowledging it is twofold. One is a person is less likely to repeat that pattern of behaviour in the future. But secondly, the family member is hopefully going to express some of their annoyance at that time. They may say, oh no, you were unwell, don't bother, forget about all that. No, you must allow them express their annoyance and anger. They're bound to be annoyed and they're just really suppressing it. So having that out in the open in an understanding way is important. But again, it must only be done when the person's mood has stabilised. Sometimes people want to go and do it when they're high. To conclude, bipolar disorder is an understandable condition. It has its do's and don'ts, it has its corners, its edges. It can be a very destructive condition, but the sooner people who experience mood swings like that take heed of the condition and address it promptly and apply knowledge to it and not run from it, the sooner their mood will be stabilised. The vast majority of people who attend to the condition do get it stabilised. For some aspects of it, it settles within a matter of months. For other people with rapid cycling mood disorder, you could be waiting a couple of years between one thing and another, getting it absolutely stabilised. Many people that I know with bipolar disorder over the past 40 years are maybe seen twice a year for mood reviews, medication reviews and so on, and they get on with their lives in terms of being within their families, working and being active members of society. Thank you.